Debunking Mental Health Myths, Separating Facts from Fiction for Better Understanding. My name is Ivian. I am a psychologist at Mathare Hospital, and I am delighted to be your co-host and moderator for today. So today's webinar is part of Mathare National Teaching and Referral Hospital's activities for Mental Health Awareness Month. As Dr. Mushero has mentioned earlier, our theme is movement for mental wellness. And mental health is a critical aspect of our overall well-being, and it should be as important as we take our physical health. So our goal for today is to shed light on some common mental health myths and provide you with accurate information so that we can foster understanding and hopefully also reduce stigma. We are honored to have a distinguished speaker with us, that is Dr. Musheru. She is a highly respected consultant at Mathare Hospital. She is passionate about mental health promotion, and she works tirelessly to demystify and destigmatize, seeking help through telemedicine and social media. With her extensive experience and deep knowledge in the psychiatry field, she is the perfectly positioned person to be able to take us through this particular webinar. So before we begin, I'd like to remind everyone that we're going to have a Q&A section at the end of the presentation. So please feel free to type out your questions in the chat box throughout the webinar. And also, if you have any myths that you would like us to debunk for you, please also include it in the chat box. We will address as many as possible during the Q&A. So without further ado, please join me in welcoming Dr. Eva Monique Musheru Wangombe. Dr. Musheru, thank you so much for being with us here today. The floor is yours.
Good evening once again. Today, I'm honored to be part of this presentation and to discuss healthy habits on a daily basis, which we can take up to ensure that we are better mental health instead of just surviving, and we make sure that we are thriving. So I'm going today to talk about myths and realities in mental health. Join me on this journey. So I want to make several disclosures as I make this presentation that these slides that we are using for illustration may contain some pictures which we have no copyright. The target audience is the general public for purposes of mental health awareness creation, and we will avoid as much as possible discussing individual patients or things that may breach on doctor-patient confidentiality. Now, the outline for today's presentation, we are going to look at what stigma is, how we can reduce stigma, how we can collaborate to make sure that our patient, our awareness session, we make sure that people get the right information wherever they are. And then Memphis and Ivy Ann are also going to address the various myths and the facts. So I want to talk about the Kenyan situation. This is not the first webinar, so you may have heard this before, that from our Kenyan statistics, 1 in every 10 of us suffer from a common mental disorder. By a common mental disorder, I'm talking about anxiety, or depression. Then, should you visit the nearest health facility near you, a general outpatient setting? 1 in every 4 of the patients sitting on the queue tend to or would be suffering from a common mental disorder or a mental health problem for that matter. But they don't have it written on their faces. They don't tell you, this is what I'm suffering from. So even for the mental health professionals, for the doctors, other clinicians, you have to have a high index of suspicion so that these patients who keep coming to hospital, sometimes with non-specific symptoms, what we call hapa syndrome. Today they're having headache. Next time they're having joint aches, backache. They're having pains all over the body. You do all tests and the tests are all normal. Would you consider asking them a few questions like whether they have ever found life not worth living, or whether there is something that is happening in their household, at their workplace, that they may not be happy about or that they may be struggling with, so that such a question can trigger a lot of information that we may need to help these patients and help them to stop doctor shopping. Because it is natural for you and me, if I went to hospital X, I tell them I'm having hii typhoid ambayo haiponi. Sorry, I'll use Kiswahili because sometimes our patients will say that to us. But I'll also translate and say sometimes they have symptoms, maybe abdominal pain, gastrointestinal symptoms that don't seem to be going away. And they want to communicate to us that we are not being effective in our services. Maybe if you ask an extra question about their social life, who they live with, what they may be struggling with, or any losses that they have encountered in the recent past, you might find that these patients will actually benefit from more than just the investigations that we keep doing day after day. I'm not saying there's anything wrong with investigating patients. In fact, I do recommend that we investigate extensively any patient who presents to us. But I'm just saying we should have, we should be more vigilant now and see if this patient is really not getting better, has come to see me for the 3rd, 4th time, could there be something I'm missing? So in our Kenyan situation, from our local statistics, depression and anxiety are the leading mental illnesses, followed closely by substance use disorders. And of note is that alcohol use disorder is the commonest. The other substance use disorders also follow, but alcohol is the most commonly. The alcohol use disorder is the most common disorder. So supposing somebody lives with you, or it is ourselves, how do we tell that something could be going wrong? Because until we are able to tell that something is going wrong with us, then we are not able to seek help. So we are not saying that should you have any of these symptoms, you diagnose yourself with a certain mental disorder. You go to Dr. Google and ask him, why am I having sleep difficulties? Where am I having low mood? Where am I having social withdrawal? We are saying you need a formal mental state evaluation. So what am I saying when we are talking about these warning signs? Extremes of appetite. If you're eating too much or eating too little, there might be a problem. If you're sleeping more than usual, or you're not getting sleep, you're having trouble initiating sleep, or you're having trouble remaining asleep, meaning you have interrupted sleep, or you wake up too early, at 2 a.m., 3 a.m., you're scrolling on your phone, something might be wrong. Mood changes. Mood is a subjective feeling. So you're either happy or unhappy. So extremes of happiness, extremes of sadness could be pointers that something could be wrong. You used to be this person who was outgoing, everybody liked being around, and suddenly you want to lock yourself in the room, you want nothing to do with people, you're conspicuously absent during social functions, kindly note that this could be one of the problems. What about problems thinking? Sometimes you're talking to someone and you find you're not able to remember. I mean, you're having trouble with your concentration. You can't remember things with ease. You're forgetting people's names. Sometimes your speech is hard to explain. Then there might be trouble. What about heightened sensitivity to things like sight, sound? You might be seeing things other people are not seeing. Those are hallucinations, visual hallucinations. You might be hearing people who talk, and these people are talking about you or about others, and they can be quite annoying. Those could be auditory hallucinations. The other increased sensitivity to other senses. We have five senses. There is sight, there is hearing, there is smelling, there is tasting, and there is touch. So if there is something you're feeling crawling under your skin, and indeed you can't see anything, then something could be wrong. What about a situation where you don't feel you have no initiative anymore? You're just, I mean, you just exist. Then apathy can show, I mean, can actually be a pointer towards mental illness. Then now when we talk about unusual behavior, there might be some odd and characteristic behavior that you see or is observed by others. Kindly seek help. What about areas of functioning? The areas of functioning we talk about, and this is why people need treatment. By treatment, I don't mean medication. I mean, you need to either talk to someone or you need to change the way things are being done. Then it's either you're not functioning well at school, work, or even social activities. So now what about stigma? Stigma is defined as a label. You can imagine somebody just decides to call you cheesy. That is the Swahili word for somebody who is psychotic, or somebody who refers to you as a zombie, or somebody who, they give you, even in epilepsy, people get labeled because of the seizure and the fact that their behavior is different. Let me remind us that when we are talking about mental health, we are talking about how people behave, how they think, and how they regulate their emotions. So you can be stigmatized because people will say that maybe the weather is bipolar or things like that, things that keep changing and they seem to be unpredictable. So there's that aspect of a label. So this label can be given to you by other people. That is what we call public stigma. Sorry for the spelling mistake. It's a negative or a discriminatory attitude by other people. What about ourselves? We may suffer from internal shame and we feel we are not worth. We look at ourselves as different and we actually start avoiding ourselves. I mean, we start avoiding being with other people. That is self-stigma. Then now there is what is called structural stigma, where things are not working for you in terms of the policies government is making are not, I mean, they're against, I mean, they're now limiting opportunities for you. Private institutions, churches, wherever you go, a mosque or wherever, people are not giving you the opportunity because you're living with mental illness. That is stigma. Then now, what are the effects of stigma? Why are we trying to destigmatize mental health problems, mental illness, and promoting awareness about good mental health? It's because when you have a label, you feel hopeless. You suffer from low self-esteem. You find it difficult to interact with others at work, at home, in public transport, because people have already given you a label and you feel you don't belong. Then you find that there are people who will hide their kin. They will not bring them to hospital. And this will lead to a delay in seeking treatment or even following up on treatment because you don't want to be seen queuing at Mathari Hospital or queuing at a psychiatrist's office. And you will find that this does affect the way we seek our health-seeking behavior. Also, people isolate themselves. Who wants to be labeled? Who wants to look like an outcast? Who wants to feel they don't belong? They tend to be on their own. They'll spend time in closed up, holed up in their rooms or their houses. They don't want to talk to their neighbors, and it becomes a big problem. Then what happens to the family and friends and people who live around them? These people don't want to, they don't understand them. They have labeled them. They don't want anything to do with them. So then, even if somebody was to give you a lift and take you to hospital, or to give you the consultation fee to go to hospital, or to buy you medication, they don't want to be seen queuing at a pharmacy with a prescription for an antipsychotic or an antidepressant. And sometimes it even interferes with the way our patients get their medication because probably the patient doesn't look like the medication that is prescribed on the prescription pad. And sorry for the spelling mistake again. Now, there are few opportunities for people living with mental illness. So you'll find that some schools, because of their behavior, they're not able to fit in. And this child, should they be seen, should they be started on treatment, you will find that they're able to fit in the school. They're able to go to work like other, if it's an adult, they're able to work like other people. They're able to come for social function. They're able to be accommodated. Imagine you're in a situation where you're seeking for housing, and the last episode you had, you broke all the window panes. The landlord may not be very willing to have you continue being their tenant. Or if they have any idea that you're such a person, they may not want to risk to give you any housing, even if you're willing to pay the rent. Then health insurance sometimes can be a big deal. And we have seen situations where, despite the fact that the Mental Health Act is very stringent and it talks clearly that you should not be discriminated because you have mental illness, sometimes the insurance will say we don't cover for it. And examples would be somebody has attempted suicide and the insurance will pay, the insurance will then say that this is not covered because it is self-induced, while we know that indeed this person is suffering from probably severe mental illness, is suffering from severe depression, and this person needs help. But because what brought them to hospital was either they had attempted suicide or through a drug overdose, the insurance declines to pay and they are unable to get help. Also, substance use disorders. Some insurances will be they'll say that is an exclusion. Usually on the insurance form, the first page is very visible, very good print, size 10, where you can read everything. Then now goes the other side, where there are the exclusions, which is small print, which we sometimes are not sure what it is, but we sign. And then after that, you find you're in hospital for a substance use problem, but the insurance will. But remember, you're still a patient. So then what about the relatives and friends who internalize the stigma? Sometimes they even blame themselves. And even as they walk out of their compound, they're thinking, oh my God, does the neighbor think I treat my kin so badly as to make them depressed? So that people think that you can cause another person's mental illness, which is not accurate because you can have associated factors, but it's unlikely that you're going to be the cause. Otherwise, then we would quickly then say, well, if this is the cause, then discontinue or disengage with the cause, and then after that you will be well, which is not true. So those are some of the myths that or somebody can actually cause you to get hospitalized. No, it could be an associated factor. It could be a stressor. But the fact that you have depression, you have anxiety is a diagnosis and you need treatment. So this stigma being associated with somebody who is mentally unwell, could I be the cause, or could these people be blaming me, or could they be thinking I'm not doing enough, I'm not giving them enough food, I'm not giving them their basic needs, and that is why they're unwell? Then we need to reduce stigma. So how do we reduce stigma? Stigma can be reduced using public health approaches, where if, for example, you meet the person, you have an in-person consultation, or rather, you're meeting with this person and you're sitting with them. Somebody who has mental illness, you're able to sit with them, you're able to have a meal, then that destigmatizes. It makes you stop thinking that they're very different from you or they're dangerous people. It also stops you thinking that the fact that you have sat next to them, you can then suffer from a mental disorder. A video, if it is done very well, it can actually help destigmatize, so that somebody living with mental illness is living their daily life. They're going to school, they're taking their children to school, if they're teaching or if they're medical professionals, they're going to work, they're contributing effectively to their community. Then that can actually help us destigmatize this, to destigmatize mental illness. Then now, people with lived experience, I need to emphasize this. The fact that whenever we have World Mental Health Day, World Suicide Prevention Day, World Bipolar Day, we invite people with lived experience. Who are these people? A patient who is in recovery. What do I mean by recovery? This person is taking their medication, they're back to work, or they're doing something productive in the society. These are people who are living with their families and they're able to get their experience. This is how I presented. These were the tests that were done. This is the talk therapy that I received. This is the medication I took depending on the diagnosis. And here I am today in front of you talking about this condition. I have lived with it. I can tell you there is hope. That is a person with lived experience. Then we have social marketing campaigns on social media, on print media, on television, radio. All those can help us destigmatize. And then we have specific people who hardly get help. Young people might be they're using drugs as a group, or they might be in college or campus. Nobody knows they're using the drugs. We also need to target these people and tell them it is okay not to be okay. Also in the military, where sometimes people are scared. Well, if I'm diagnosed with this condition, will I ever hold a firearm? This is my lifeline. What am I going to do if I'm retired on medical grounds at party? We need to talk to these people so that they come out and seek help, even if they're in the military. Then undocumented populations, you might be somebody who is an illegal immigrant, or somehow your visa has expired and you don't want to seek help because then you're likely to be, to be submitted to the authorities or whatever. These people are people we need to target so that they also get to know that stigma is real and that this should not prevent them from seeking help. The fact that they have been labeled illegal immigrants does not mean they do not have mental health needs. Now, individually, we have talked about the public, how the public can reduce stigma. What about you and me as individuals? How can we reduce this stigma? We need to learn to talk openly about mental health problems. Just like I would say, I suffer from diabetes and I am on insulin, 10 international units, 3 times a day. That is the way we should normalize the talk. Mental health treatment, like the last statement, be honest about your treatment. Normalize mental health treatment like you talk about anything else. Educate yourself about mental illness, because ignorance is no defense. And you see, the fact that when you're now well educated about your condition, you're able to educate others. You're also able to make informed decisions. So that sometimes we have trouble where probably a patient is in a general hospital and now they have been found to have anxiety, but now it is said the patient has to be discharged because the reason that brought them to hospital is not anxiety. They had difficulty in breathing. But don't forget, this anxiety could have been the cause of the difficulty in breathing. But now, if you're educated on the psychoeducation for the family and even for the patient, that now indeed we have done all the tests, but now this difficulty in breathing was because of anxiety, and the anxiety is being treated using psychotherapy. You have a psychologist on board, you have a psychiatrist on board to give medication, and there is hope and you're going to be better. As opposed to a situation where, oh, now, they have said I have no physical problem. So then I need to be discharged. Or the relative will say, oh, you mean this person has no physical problem? So then are they faking it? Because people will not understand that anxiety, depression, which you can't touch, can actually cause. But once we educate people, then we reduce stigma. Then let's be conscious about language. Let's avoid telling the patient, you're responsible for your situation. You're the cause of this problem. No. Try, and even as you try to encourage them to seek help, you tell them, probably you've been looking unwell. You look like you don't have energy. Would you want to seek some help? Something like that, as opposed to telling the person, you're lazy, you're good for nothing, you sleep all day. I mean, such a person will not go help. Then encourage the equality between physical and mental health. What do I mean? Saying that physical health is as important as your mental health. So there's no difference. There is none that is more superior than the other one, or one that requires more priority than the other one. So it doesn't mean if you're diabetic, you're hypertensive, you also have bipolar, the day you don't have money, you don't buy medication for bipolar, you buy the one for diabetes and hypertension because those ones are more severe. So it's important that we encourage the equality and to show you that you need to be holistic in your approach. Both your physical and your mental health are interrelated. And without good mental health, even that physical health will be neglected. If it is neglected, it's likely to be the one to kill you before the mental health condition kills you. So you will find that patients with mental health problems will die of physical problems, as opposed to a situation where it's a mental health problem that is the immediate cause of death. Unless, of course, it's a case of maybe attempted suicide, completed suicide, or things like that. Okay. So then what about employers? We can't leave employers out of this, because employers need to train leaders in the organization to identify these warning signs and also to make referrals. If anybody is in your department and is now absenting themselves from work, find out, could there be something wrong? You've noticed that nowadays they're walking very slowly. They hardly look at you when they're talking to you. They look sad. They used to join others in the cafeteria to eat food. Now they don't. Now, can you find out whether this person has an emotional problem? And you can make referrals. Most companies will have a counselor who the staff members can talk to. That is a good place to start. You start by referring them to see the counselor. Then you can then tackle their disciplinary action. You can take disciplinary action. If indeed you're sure that this person is not unwell, then kindly mention during your meetings that you want to leave the park. You want people to be well. You want good employees, superb employees. You want people who are performers, and encourage people to seek help if they're having difficulties. Then if it's somebody who has been discharged from hospital, you may need to accommodate them. You may need to give them light duties. You may need to adjust, give them some flexi working hours because probably they're on medication that makes them a bit drowsy. So then they may need to come in later and leave earlier. Kindly be welcoming to the need for accommodations, especially post-hospitalization. After that, the patient will be okay, will be back to normal functioning. So what about groups? At population level, we want people to have a positive attitude change. Let people look at the positive aspects of this person who has been treated and now is able to be part of this community. Then now, if it's people living with mental illness, group level anti-stigma interventions where they have support groups among themselves and they are able to talk about stigma and how to go about the stigma, overcoming stigma, whether it is public stigma, whether it is self-stigma, or by the institutions, which is the structure. So now I want us to talking about one's mental health. It's important that you rehearse, or like you have an idea how it is that you will go and seek treatment. Sometimes patients will come and they're like, well, I've been referred to you, but I don't know how this goes. It goes like this. Talk to me or talk to your primary care provider. They will take a history. They will guide you on what it is they need to know from you. But before you go, prepare ahead of the visit. It might be a bit nerve-wracking. You're not sure, should I say this? Should I not say this? Is this going to embarrass me? Will I sound lazy? Will I, there are all those misconceptions that the clinician who is seeing you, much as they are non-judgmental, you're trying not to look very bad. But you can write down your concerns. Write the list of medications that you've been on. If you have previous medical records, kindly carry them with you for the appointment or for this review. And then consider bringing a friend or a relative. We are not saying that you cannot be seen alone. You're going to be seen alone. But the friend or relative can be called in at some point and just say how it is that they have observed you. Because in mental health, we have the subjective report, which you're giving yourself as the patient, but there is the objective report from an observer. The person can be your friend, can be your workmate, can be your relative. Then also sometimes when recommendations are made, the patient might be very unwell, and we may need somebody to help take the person to take the person for investigations, follow up on the appointments. So that is why it is good to bring in a friend or a relative. And also it helps destigmatize the fact that, yes, they came with you, they saw you when you are unwell, now they can bring you when you're feeling better. And it also helps them feel they're playing a role. Then be honest with us and ask questions. There is no question that is embarrassing. Please ask the questions and we will answer. So how do you help a loved one cope with mental illness? One, you recognize the warning talked about. In addition to helping recognize those warning signs, start that conversation we talked about, that difficult one, even among the doctors, of saying, I'm referring you to a psychiatrist. Sometimes it's difficult and they'll say, I'm referring you to another doctor. And this doctor will talk to you. Then the patient says, about what? And now the doctor is like, oh my God, now what do I tell this person? will they ever come back to me if, I mean, I thought they have a mental illness. They'll think I'm really, I mean, I am thinking of them so badly or something like that. So try and start that conversation. So that conversation needs that you show some patience, be caring, and avoid being judgmental. Whether you're the friend, the brother, the sister, the mother, or whether you're, a clinician, whether you're a nurse, a clinic officer, whether you're a medical officer, you're another fellow specialist other than psychiatry, or even a psychiatrist, and you want to refer the patient for psychotherapy, please start that conversation. It needs a bit of patience, it needs a lot of time, but it is worth doing. Then educate yourself as a person who is helping somebody cope about mental health conditions, so that we'll talk about some of the things people are told about snapping out of it. Well, I mean, you can, I mean, you can just snap out of it. What is the big deal? And what is, I mean, and everybody suffers from these symptoms every day, which is not correct. So educate yourself about mental health conditions so that even when you're advising somebody or when you're supporting them or helping a loved one, you also do not utter those, those myths or statements that sound a bit, that make them feel, uh, they don't feel validated and they feel like they're not trying hard enough. And there's nothing about trying hard enough. It's about seeking help. Then help these people address barriers. If they don't have anybody to take care of their child, kindly help them find somebody or take care of their child. Communicate with their employer that today they are going to hospital so that the employer does not lay them off thinking they have absconded. So what to say? 1, thank you for opening up to me. 2, is there anything I can do to help? 3, I'm sorry to hear that. It must be really difficult. You know, you're validating them. People get better. Give them some sense of hope. But please don't say it could be worse. Just deal with it or snap out. Or you've got to pull yourself together. Please don't say that. We've all been there. Everyone feels like that sometimes. That is not true. You have brought this on yourself. Please don't say such things. Now, collaboration. I'll want to be a bit fast. We want to work with antenatal clinics to make sure people get to recognize that they need to take care of their mental health. When pregnant, postnatal clinics, when they have delivered, a patient or somebody who has depression, for example, will not go for antenatal clinic. They will not bring their child for postnatal clinic. They'll not bring them for vaccination. So we need as much as possible that we collaborate with antenatal clinics, postnatal clinics to make sure that the mothers, their children are healthy. Then we follow the children to school and make sure we have school programs, youth programs, then spiritual leader trainings, because many people, when they're feeling things are not right, they go to their religious leaders. So spiritual leaders would help identify people who are suffering and refer them appropriately. Traditional healers, they need to be trained. Health workers, we need to train them time and again so that even if what we call a general health worker, meaning you're not in mental health, you're in the maternity, or you're working in the community, the community health clinics, you need to be able to identify people who are suffering from mental health problems and refer them appropriately. Even the volunteers, the community health volunteers, they also need to be trained. What about law enforcers? If, for example, someone is having bizarre behavior on the streets, or the first person who is called is the law enforcer. They need to know where to take them, not to lock them up, but to take them to hospital for treatment, because the law provides for that. If, for example, somebody is disruptive and is destroying property, or has knocked a car maliciously, that's somebody who needs, or has thrown a stone to the windscreen. That's somebody who may need help. Instead of locking them up, can they be brought to us for treatment? What about the judiciary? There are people who are in conflict with the law, but they're mentally ill. We call them mentally ill offenders. Let them be referred to us for treatment. Correctional services, that's the prison. Let them screen the patients, let them refer to us. Employee-assisted programs where employee wellness, situations where there are flexi hours, and things like that can be organized in organizations. Now, there is a task force on mental health in Kenya. It was constituted, and it gave a report. And the report is a 104-page document online. It talks about the Kenyan situation as is, because the task force members visited all the counties and came up with a report and recommendations. And the recommendations are being implemented one by one to make sure that we are happy, and we are a happy community, and we are healthy. So now, according to the task force on mental health, there was the recommendation of the launch of anti-stigma mental health education campaigns using public barazas, the ones for the chief, where they go to talk about immunization. Mental health should also be discussed. Sports, mental health should be discussed. Like, for example, right now for mental health, sorry, the Mental Awareness Month, there are dances, like, for example, you will find there are tickets being sold for dancing. And also, Mathari Hospital has had Zumba for its staff members. And sports are important when it comes to anti-stigma campaigns. We need to use the media, art, and cultural activities to make sure that we are doing the anti-stigma campaign. Then now we need to include the people living with mental illness in the education sector, in employment, skills, training, policies, development. They need to be included. Then there is a training on quality rights. It's online. It helps professionals know how to protect, respect, fulfill the human rights of people living with mental illness. It's also important for those living with mental illness, or those who are now, when it comes to the myths, my colleague Ivy will look at this in detail. But before I hand over that to her, I would like to tell you that mental health, we said mental wellness, mental illness, they're all in the same spectrum. It's just the fact that you can tip either way. You can either be mentally well or mentally unwell. And people with mental illness do enjoy periods of positive mental health, a situation where they're without symptoms, they're able to contribute productively to the society. But we need to ensure that we maintain that balance. So in the mental health continuum, you can either be positive and healthy, or you're in the middle there. You're having trouble dealing with one or two things, the stressors. A stressor is something, stress is defined as a situation where you doubt your capability to deal with a situation, either socially or personally. So that person could be there. or there are those who are suffering from severe mental illness. Then now, it's important for us to have a mental health meter and ask ourselves, are we at the bottom where we are all smiles? Everything is great, we are smiling, or are we going towards the crisis where you might be coping, so you have some stressors, but you have some support which you're using, or you're struggling because you're not skills, or the ones you were taught have stopped working, and you may need some support. Or are you in a crisis where you need help and support now? I would like to hand over to Ivy to continue with the rest of the presentation. And thank you very much for listening to me.
I think Dr. Micheru has done a good job. We can clap for her even as we continue writing our questions on the Q&A. And then we proceed. I think we'll start by reading a case study on the mental health in Kenya, and it's drawn from the publication of January 2020 by Ann Ngugi and Basilo Mutahi. And I'm going to read the case study as we wait for Ivy Ann to prepare herself. So the case that we're going to be looking at is the mental health in Kenya. And it says, I was accused of bewitching my husband. So it talks about Esther Kiama was working as a teacher in Nyeri, Central Kenya, when she received the call. Her husband, David, was unwell, and it is not a minor illness, the caller emphasized. And then explained it's a mental illness. At that point, in 2005, Ms. Kiama had not seen her husband much over the previous years, as he had moved to another town to set up a business. On the times she visited, she had not noticed his health problems, but once the call came, Ms. Kiama left immediately. To find him. Just give me a moment. Sorry. Sorry, so we can proceed. Sorry about that. So it says, but once the call came, Miss Kiama left immediately to find him. We had to get him home so that he would get medication. She told the BBC. Miss Kiama said that her husband would talk to himself, throwing his arms about, appearing to be talking to people while there was really no one he was talking to. It got worse when he came home, and I would leave him in the house. And one day I found that he had burnt the ceiling, saying there were strange people he was looking up there. It was as if her husband had transformed into someone she did not know, and she did not understand what was happening. You have bewitched our son. She decided that she would take him to the hospital, but her relatives would not let her. They accused Miss Kiama of casting a spell on her husband. His dad came to take him and said, I have been told that my son is sick. I have come because you have bewitched him. The forceful removal of her husband of 15 years was a traumatic experience for her and their 4 children. I was shocked at first, but I'm a believer, even though it really shocked me. I believed this would end, she said. Meanwhile, she would see that her husband's health was deteriorating. But because of their belief that he was under a spell, Miss Kiama's in-laws did not look for medical help. For 3 years, Mr. Kiama was a burden to his parents, especially to his elderly mother, who at some point fell ill, seeing the sad state of her son. Occasionally, neighbors would contact Miss Kiama about her husband, Sometimes I'd be called to be told that he was in town roaming about, and I'd go hire a taxi and take him back. Miss Kiyama says she would at times go and cook for him, but was still blamed for her husband's behavior, and this filtered through to him. He once chased after me with a panga, a machete, saying, "You bewitched me." But I asked him, "If you kill me, who will cook for you?" He then threw away the panga, she says. Miss Kiyama was grateful that except for that incident, her husband was not violent. Miss Kiyama said it was difficult watching someone she loved suffering so much from an illness that she hardly understood. She also struggled with the reaction she got from the friends. Men turned their backs on her despite her husband's condition. Miss Kiama was not going to abandon him against all the advice from her friends. I told them it was because of the vow we had had at a church wedding. He came to pick me from home as a young bride. To say the truth, he loved each other. To say the truth, we loved each other very much. We had 4 children. In the end, Miss Kiama decided that she was going to reclaim her husband from her in-laws. After 3 years, I told my children, we are going to steal that, she said. Together with her children and a psychiatrist, they devised a way to get her husband out of his parents' home. By then, she said, his finger and toenails had grown long and dirty, and it would take days to clean them. His beard his beard and the hair had overgrown so much that it gave him a horrible appearance. He was like Nebuchadnezzar of the Bible, totally unkempt. Back with the children, Mr. Kiama's bipolar disorder was then diagnosed, and he was admitted to the hospital for about 2 months. Since leaving the hospital, he has been recovering at home, although he is still on long-term medication. The family is now back together. So the doctor has counseled my children how to live with their dad, and they should love him the way he is, and it has worked. So that is what Miss Kiyama said. So after reading that story, I would hand over to Ivy to continue debunking the myths. Thank you.
Hello. Thank you so much, Memphis. We're going to continue with debunking the myths from the perspective of this case study, because as we have seen in the particular case studies, there's a lot of myths and misconceptions that have come up with the cultural myths, the stigma that surrounds a household and how it even affects the children. So using that case study, we get a context of a typical Kenyan situation. Thank you so much, Memphis. And so the key highlights that we got from that particular presentation are: one, the stigma that comes from a person getting mental health issues. So let me present the second slide, just a moment. So the key highlights that we get from that excerpt that Memphis has shared with us is first the misunderstanding of mental illness. So from the excerpt, it shed light on the profound misunderstanding and stigma that surrounds mental illnesses in Kenya. So Esther Kiama shared this story with BBC about her husband, David, and it displays symptoms of a mental health disorder. Yet his behavior is misinterpreted by the family members as being caused by witchcraft or spells, which highlights a common misconception that mental illness is as a result of supernatural forces rather than biological or psychological factors. Another thing that is highlighted in this is the impact of cultural beliefs. As you saw in the excerpt, Esther's relatives accuse her of bewitching her husband, reflecting the prevalent cultural beliefs attributing mental illness to supernatural cases such as witchcraft. Um, Also, it talks about stigma and social rejection. You can see the way Esther's friends isolated her, the way her in-laws accuse her of bewitching David, reflecting the deep-seated cultural beliefs that we have. There's nobody who in that whole particular family stood up and stood with this lady, even even in this in this age of the internet and all the knowledge that is out there. There's no one who stood up for her. It took up to 3 years for her to go and tell her children, tunaenda kuiba baba yako. You can imagine that kind of a scenario being faced with her children. So the myths that have been debunked in this particular excerpt are that, for one, that mental illness is caused by witchcraft, and two, that mental illness is a sign of weakness or personal failure. And another one is there is no hope for people with mental illness. Once a friend or family member develops a mental illness, we normally say that they will never recover. Yake imeishia hapo. Another myth that has been debunked is that children do not experience mental health issues. You see the way, even as much as the article primarily focuses on Esther's husband's struggle with mental illness, it indirectly acknowledges the impact on their children, who had to witness their father's illness and eventually recovery. This challenges the misconception that children don't experience mental illness. So while we're there, I'd like us to look at the Q&A section and post as many myths and misconceptions that you have, or any questions that you may have on the same, so that Dr. Musheru and I will try as much as possible to go through each and every one of them and try and help to explain. While we're there, I'd like to share some common myths and misconceptions so that we can also debunk them. So the first myth that we hear is that mental issues are rare. So that one, we hear it in many ways. People say, hizo ni shida za wadosi. Those are people from a particular race are supposed to have such problems. But according to the World Health Organization, 1 in 4 people will experience a mental health condition at some point in their lives. So it does not necessarily mean that a person has a disorder, but each and every one person, 1 in every 4 people, will experience a mental health condition at some point in their lives. The second mental health issue, the second one is that mental health issues are a sign of weakness. You've seen also in Esther's story that people also it to be a sign of weakness, but she came through with resilience, even with the stress that came with her situation. She came out on the top of it. So mental health issues are not a sign of weakness or personal failure. They are medical conditions that often result from a combination of genetic, biological, or environmental factors. So this is why sometimes it can be said that it runs in the family, because there are genetic factors that make people more predisposed to experiencing mental health conditions. There are also biological and environmental factors that make people more predisposed to this particular mental illnesses. But it does not mean that it is a guarantee. It is just that some people have less or more predisposition to mental illness based on their genetic, biological, environmental, or psychological factors. Are we together? Can I see some thumbs up if we're all together? Okay, okay. Ah, I see someone is even laughing. So the third one, mental health issues cannot affect me. This one, we hear it a lot with people from higher social economic situations, people who say only women get depressed, only men cannot have anxiety. People have all these ideas. They say mental health issues cannot affect me. So no one is immune to the possibility of experiencing mental health challenges at some point in their lives. Like we've seen in the statistics, 1 in every 4. Ignoring or denying the possibility of experiencing mental health issues can prevent you from recognizing or addressing your own struggles. So you find that some people would say, this is a man, there's no way you have anxiety. In a way, you minimize and you disqualify this person's situation. And therefore, by that stigma, you prevent them from being able to go and access help. So let's move on to the next one. You can just snap out of it or toughen up to overcome mental health issues. We've had this a lot that tell our friends, wejikaze, toughen up, wewe ni mwanaume, snap out of it. You can finish this work when somebody may be experiencing depression per se, and maybe they're lacking motivation or they lack interest in the things that they used to enjoy. They're told, snap out of it. So mental health conditions cannot be overcome simply by willpower or determination. They require appropriate treatment, which may include therapy, medication, some lifestyle changes, or a combination of these approaches. The fifth one is that people with mental health conditions are violent or dangerous. So this one has been used over and over again to perpetuate stigma against people with mental illness. But you find that most people with mental health conditions are no more likely to be violent than anyone else. Everyone has capability to be violent. Having mental health issues does not mean that automatically this person is violent. Only 3 to 5% of violent acts can be attributed to individuals with serious mental illnesses. So news headlines and about crimes and all those documentaries have really perpetuated this myth that people with mental illness, mental health conditions are violent or dangerous. It does not necessarily mean that one means the others automatically. So moving on to the next one. People say that children don't experience mental health issues. Children do experience mental health issues. Even very young children may show early warning signs of mental health concerns. These mental health conditions are often clinically diagnosable and can be a product of interaction of biological, psychological, and social factors. Half of all mental health disorders show first signs before a person turns 14 years. So that is half of them. They show before a person turns 14 years old. And 3/4 of the mental health disorders begin before the age of 24. And people still say that children don't experience mental health issues. Early intervention and support are crucial to promoting positive mental health outcomes for children. You find that only half of children and adolescents with disability or mental health conditions receive the treatment that they need. Because you find that these mental health conditions are often clinically diagnosable, but they do not seek help because there's a belief that children do not experience mental health issues. They say it's just adolescents that they're going through hormonal imbalances or they're going through adole. That's what people say in Kenya. But that minimizes and reduces the chances of this young person having early intervention and hence having a more better quality of life. So let's move on to the next one. Therapy and self-help are a waste of time. Why bother when you can just take a pill? So treatment of mental health condition varies depending on individuals, and it could include medication, therapy, or both. Many individuals do best when they work with a support system during the healing and recovery process. Therapy provides a supportive environment to address underlying issues and then develop coping skills and make lasting changes. Self-help techniques such as mindfulness, exercises, and stress management complement therapy and promote overall well-being. So you find that medication is usually prescribed, but it not all the time is it the first line of treatment in all mental health conditions. Medication is often one part of a broader treatment plan. So evidence-based therapies such as CBT, which is cognitive behavioral therapy, normally go a long way to help people develop better, healthier coping skills to be able to cope with mental health conditions. And lastly, we shall go to there is no hope for people with mental illness. Once a friend or family member develops a mental condition, they will never recover. This one has perpetuated a mindset of stigma in that people with mental health are hidden in homes. People do not get access to mental health services. People are denied opportunities for treatment even from a young age. With appropriate treatment and support, many people with mental health conditions can lead fulfilling and productive lives. Recovery is possible, and there are many effective treatments available, including therapy, medication, and support groups. Recovery refers to the process in which people can live, work, learn, and participate fully in communities. Mental health, yes, some conditions can be very debilitating, but with the right treatment, therapy, medication, and support, everyone can be able to experience life and have a better quality of life. I think we shall close there on this particular slide and go over to the Q&A. Dr. Musheru, let's look at the Q&A session and try and debunk some of these myths. I shall encourage you to share with us all the myths and misconceptions that you may have at this point.
Good evening once again. Thank you for the questions that you're posting on the Q&A. I'll start with the myths. A myth: for someone to present with mental illness, mental health symptoms, they must have used drugs. Yes, true, that is a myth because substance use can trigger a mental illness. There are also mental illnesses which are classified as substance-related disorders in the DSM-5, which is what we use for classification. So, and the patient must meet a certain criteria for the diagnosis to be made. But indeed, that is a myth that you need to have used drugs or substances of abuse to be diagnosed with a mental illness. Thanks for the insight, such an insightful session. Is there a role for exorcism as happened in religious world, especially in cases such as schizophrenia? No. Schizophrenia is a mental disorder. It's a chronic, relapsing mental disorder characterized by abnormal beliefs, abnormal experiences like hallucination, disorganized speech, disorganized behavior, and what we call negative symptoms, a situation where the person is not social, has no logical speech, sometimes they get apathetic, they have anhedonia, they're not interested in pleasurable activities anymore, they're not able to take care of their hygiene because of that. And schizophrenia research is still going on. The main is medication combined with talk therapy, what is called CBT for schizophrenia, cognitive behavioral therapy for schizophrenia, for them to realize that, and to realize that those symptoms are indeed, I mean, like, for example, the voices are not real. They are symptoms of the illness. And once the condition is treated or the disorder is treated, the voices disappear. So now mom is at cancer remission stage. As a family, we are happy that she has responded to treatment. That is good news. However, she's having some digestive disorders, which her doctor has attributed to the side effects of radiotherapy. Sorry about that. We have observed that she's preoccupied with the distressing rather than the positive treatment outcome. We feel she needs counseling, but we don't know how to communicate this to her, as we fear she might feel either we don't understand what she's going through or we think she's going mad. Sorry about that. What is your advice? Your fears are valid. You don't want to look like you're judging her, like she's not trying enough, like she has not achieved anything positive. But terminal conditions need supportive psychotherapy, which is counseling. The oncologist who is seeing her would be best placed to introduce the conversation. As I said, this conversation needs some tact. The oncologist can then introduce the aspect of her being seen or also having counseling as she continues with the other treatment, as part of the treatment. And most cancer centers also have counseling psychologists, they have counselors who are dealing with the patient. So probably you may need to see the doctor as you give feedback and say that you have noticed that she is a bit distressed. If the counseling aspect could be introduced for both the family and even for her. Then I can see another question here. Is OCD a mental health issue? Yes, it is a mental health diagnosis. It's a situation or it's a disorder where somebody is preoccupied with something like that, so that it causes you so much anxiety. You have intrusive thoughts that the table is dirty, that you're compelled to keep washing your hands. So you get a compulsion, which is the ritual. So there is the intrusive thought, which is the obsession. It leads to a ritual, which is now the compulsion. Then it becomes a disorder because it prevents you from functioning properly or functioning well socially and occupationally. So that you might wash your hands the whole day. You might be preoccupied with the door not being locked, and you can't sleep at night because you keep pacing up and down your room, going to check whether the door is locked. That's so OCD, obsessive compulsive disorder, is a mental health disorder which requires treatment. Treatment, I don't mean medication. I mean a combination of behavioral strategies, sometimes medication. But as I said, the patient must be formally evaluated for us to know what they need, what their treatment requirements are. Number two, Who is better placed to diagnose mental health issues, a psychologist or a psychiatrist? Now, diagnosis of a mental health disorder can be made by the primary healthcare physician near you. It can be a nurse, it can be a clinic officer, it can be a general doctor, it can be a psychologist, it can be a psychiatrist. So long as the person has training to identify the warning signs, make a diagnosis, conduct the relevant investigations, and refer appropriately. We work as a team. A psychologist has studied human behavior. A psychiatrist has to be a medical doctor who has specialized in mental health. Now, the person near you may be a psychologist or a counselor or even a school counselor. They are able to tell that this person is not able to function. If they're able to make a diagnosis, then they're able to make a diagnosis, know whether it is something they can handle or it's something they need to refer. Sometimes the psychologist may be having sessions with a patient, but the patient is not improving. And the referral may be made to find out exactly why is it that this patient has severe symptoms that are interfering with therapy. The person is hallucinating, somebody is deluded, is very paranoid. Those are not people who are amenable to psychotherapy or talk therapy. They need to start with psychiatrists first, then now the psychologist can be brought on board. But as much as possible, go to the nearest health provider. That person will then identify and do basic tests to find out, is this person having mental health symptoms because of a physical condition? You might present with confusion because you have meningitis. So if you have meningitis, you need to be treated for the meningitis. And the mental health symptoms, if it was confusion, if it was aggression, they get sorted out. If, for example, you're having a brain tumor, you may need first to find out this headache, then you're done a CT scan, then the CT scan shows the brain tumor. The brain tumor, depending on where it is, can be giving you hallucination. So as much as possible, the patient must be seen, evaluated formally by a qualified clinician, then referred appropriately. Everyone has some degree of madness. That is a common myth, in addition to the one that of every market has its own madman. And what we are trying to say is fact. No, madness is stigma. We need to stop using the term madness, cheesy. We need to stop using that. But to answer your question, it is indeed a myth that everybody is unwell or is psychotic. Because what this statement means is that we are all psychotic. We are either suffering from hallucinations or delusions, which is not true. But we have risk of getting mentally unwell if, one, we don't seek help for the warning signs, two, we wait until it is too late to treat symptoms. So the answer to this is, one, we are all predisposed. We should be woke to the fact that we are all predisposed to mental illness. And the earlier you identify the warning signs as an individual or somebody living with you or somebody who knows you from your posts in social media, once those discrepancies are noticed, you need a formal evaluation. Ivy, I can't see others on my side.
I can see some on my side.
Okay,
And let me tackle one that is saying a myth for someone to present with mental illness symptoms must have used drugs. So first of all, let's clarify the relationship between mental illness and substance use. Substance use can sometimes exacerbate, that is, make it worse, or co-occur with mental illness. The presence of mental illness, mental health symptoms, does not necessarily indicate substance use. Mental illness can arise from a variety of factors. Like we said earlier, it can come from genetic predisposition, environmental stressors, or neurochemical imbalances. So it does not necessarily mean that someone who has used that someone who is presenting with symptoms of mental illness has used substances. Sometimes it may be that way, but it might also be that this person has other predispositions. So also, I'd like to highlight the complexity of mental illness, that it is not solely caused by drugs. So that myth is not true. Another myth I would like to address on this list is the one that says, there's a question, a person has said, I have a family member I think needs help, but getting them to go is the process. The person says that people are stigmatizing this person due to poor hygiene. So I'm really sorry to hear about that. It's understandable that you're concerned about your family members' well-being, especially if they're facing stigma due to their poor hygiene. So the most you can do is, first of all, approach it with compassion. Start by expressing your concern for their well-being from an unjudgmental point of view. Listen to their perspective, because most of the times you assume that it is always the same thing. Probably they're on drugs like the previous myth, or amerogwa is witchcraft. Listen and validate their point of view. Maybe they may be experiencing shame or embarrassment or fear, and it's important for them to feel understood and accepted. Then you can provide information about where to go. Maybe this person does not have, offer them mental health resources and treatment options that are available for them. You can assure them that seeking help is a sign of strength and not weakness, like we have seen in the previous myths. And then you can also offer support by maybe taking them, accompanying them when they're going to get help, and also helping them to follow up. You can also try and even go a step further and address the stigma. Maybe talk to these people who are thinking that this person is just deciding to be that way. Dr. Msheru, have you seen any other myth that you would like to cover?
Okay, I would also want to address the same question you're talking about.
Mm-hmm.
The person who needs to help the family member, there is role for the family member taking the patient to hospital and applying for involuntary treatment for them to be treated if it is difficult for them to go themselves. And this can help so that the patient is treated, and once they're able to make the decisions themselves, they're able to come back for follow-up or to take charge of their treatment. Otherwise, if we take too long, it might also complicate. So the earlier we seek help, the better. So they could bring the patient to the hospital. The patient will be evaluated. Some patients are treated as outpatients, depending on the severity. But now that they've noticed that this person's hygiene is neglected, if the person can agree, they can escort them to hospital for an evaluation, then recommendations can be made as to whether the patient can be managed as an outpatient, investigations can be done, or whether they need inpatient. And then somebody is asking, can you be able to diagnose yourself that you're suffering from mental illness? You can screen. One can actually use self-administered questionnaires, which can help you screen for mental illness. But for you to have a diagnosis, you need to be evaluated. And you also need a trained person. You need a clinician to recommend any investigations you need. And then after that, they can also talk to you about or give you feedback about their findings and what the recommendations would be. But first thing, get evaluated. But the screens are there, they are available. Mood, like for example, if it's for depression, there's Beck's depression inventory. There is also Beck's anxiety inventory. For anxiety, there are ADHD questionnaires, but you shouldn't use them for diagnosis. They're used for screening. They are also used, like for example, they'll give you an idea of probably the severity of the symptoms. And they can also be used when it comes to follow-up to see we started at this, this score was your score at this particular time before starting psychotherapy, before starting your treatment. Now you're at this stage. But take care you don't get obsessed, because you can be doing the questionnaire every day to check whether it has changed. Then now you will join the people with the OCD. Sorry to say that. So that I hope I've answered the question, that indeed you can screen yourself, but if you have any shadow of doubt that your mental health is in question, kindly get evaluated. Then you can be told this, because sometimes the symptoms overlap. So a patient will be told, yes, well, I think I have ADHD, yet probably from the evaluation, they have something different. So if you have any shadow of a doubt that something could be wrong, seek help, and as soon as possible, as soon as yesterday. Then extreme alcoholism is a form of madness. That's a myth, but alcohol use disorder is the third most common mental disorder in Kenya. And even worldwide, alcohol use disorder is a big problem. It's actually among the substance use disorders, alcohol use disorder is the commonest. So the slogans about drinking responsibly, the fact that you're using a substance, you will need more tomorrow. So you get tolerant. Then immediately, then once you stop or the levels reduce in your system, you start getting withdrawal. Physical withdrawal includes tremors. Then you might also have situations where you're hallucinating, you're seeing insects, you're seeing animals, you may experience seizures, or what are called alcohol ramping. Sometimes people talk about like it's an electric current that hits them. And confusion, what is called DT or delirium tremens. So there are two forms of withdrawal. There is physical withdrawal, which I've described, the tremors, the hallucinations, the convulsions, and delirium tremens. Then there is what is called psychological dependence, where you're craving. You're wondering when Dr. Mushero will stop talking so that you can catch your drink. Or you're still sipping as you listen to me. Yeah. Okay. Then myth, mental illness is a failure to take care of oneself. That would help us maintain wellness so that you take care of your physical health, you take care of your emotional health, your spiritual health, your environment. Stop littering. Make sure wherever you stay is clean, devoid of clutter, things like those. Because why I'm not insisting about physical health is that it's talked about so much. People know about exercise, eating right. Spiritual health, yes, people are taking care of their connection with a higher being. But things like environment, where your living space, then things like your profession, make sure you're able to talk about it when you're stressed, when you're feeling burnt out. Take leave. Don't be perpetually at work, and don't take it that the work situation cannot continue if you're not there. Believe me, if I dropped dead, life will continue as usual. So then some of those things we need to take care of, and that I talked about healthcare. Then relationship between mental illness and drug abuse, that has been addressed. Ivy, are you able to see the others?
Yes, I'd like to talk about the one that somebody says, how does one draw the line between demonic and psychotic? So that one will also cover the one that a person is asking about mental health is spiritual. You can be prayed for and it disappears. So, first of all, distinguishing between experiences that may be perceived as quote unquote demonic and those that are indicative of psychosis involves considerations that we have talked about earlier. That is the cultural, religious, and clinical perspectives. So in some cultural and religious contexts, experiences that may appear as demonic are interpreted within the framework of spiritual beliefs and practices. So you can, to answer your question, you can check on treatment response. Psychotic symptoms often respond to psychiatric medication and evidence-based interventions such as psychotherapy in CBT, while demo uh, experiences that are perceived as demonic may be addressed through spiritual and religious practices. So monitoring an individual's response to treatment can help inform the diagnosis and guide appropriate intervention to that. And the next one, the question that I would like to tackle will be on the professionals, mental health professionals. I've seen that someone said that mental health professionals do not experience mental health issues. So they framed it as the myth that psychologists or mental health professionals do not face mental health illnesses. So first of all these professionals at the end of the day, regardless of what they do for a living, are human. Let's start from there. It's essential to recognize that mental health professionals, including even psychiatrists, are human beings with their own experiences. They have emotions and they have their own vulnerabilities. Remember, we talked about predispositions that are genetic, that are environmental stressors. Just like anyone else, they can face mental health challenges and may seek support and treatment when needed. I'm going to talk as a professional in the mental health space as well. It is very difficult for one to be able to go and seek help, especially in a facility where you might find yourself that you work there. And I know a lot of mental health professionals resonate with that idea. So we might need to destigmatize help seeking behavior within the profession. There's a big gap, and it's something that we'll need to work on. By acknowledging that mental health professionals can experience mental health issues, we help to destigmatize the help-seeking behaviors. It's crucial for everyone, including those in the mental health field, to feel comfortable seeking support and assessing resources when facing challenges. It's very important because we are all human. I can't emphasize enough the importance of self-care. Madare Madare National Hospital is doing a set of activities, physical activities, to really work on self-care. And we have a 30-day self-care challenge that I'm going to share with you shortly after we finish the Q&A. And also, it's okay to normalize vulnerability. Everybody is vulnerable and everyone has their own predisposition. So I'd encourage to have platforms where people can share stories of mental health challenges among mental health professionals to help normalize vulnerability and also to be able to just promote empathy and understanding just within the field of mental health. Uh,
I have
I think,
another one.
yes.
Someone asks, I have a doctor friend who has gone to rehab twice and keeps relapsing. Sorry about that. Is there any way he can be assisted? Especially from, I don't know that it's the same question, especially from the nurses and psychologists, despite insisting to see his psychiatrist. I don't know that it's the same person, it's the same timing. Now, addiction or substance use disorders are a chronic relapsing brain disorder. And the person can be treated several times before they get better. But there is hope. Have they been evaluated? Is there a comorbidity? Is there an underlying mental health disorder like depression, anxiety that is fueling this substance use? They shouldn't get tired. They should still continue seeking help. Then once they leave the rehab, are they going for aftercare? We have a Center for Substance Abuse Treatment clinic at Mathari Hospital for outpatient. They have support groups, they have the counseling going on. There are Alcoholic Anonymous groups where somebody can join. So they should get a sponsor. I still feel there is a lot of hope for this patient, and he needs to normalize seeking treatment and try it again. It doesn't have to be rehab. Can the patient be seen as an outpatient at our facility or a facility of his choice? Then the possibility of a comorbidity can be explored and see how he can get help. Then somebody asked, during the performance contract indicator at workplaces and one's achievement is below par, that is below 50th percentile, does this lead to mental illness? Sorry about the poor scores. It's really, I would say it feels very bad to score very poorly, but have you explored why it is that you're under the 50th percentile? Are you burnt out? Or is this person burnt out? Or is this person depressed and is not able to function? Are they anxious? They should speak to somebody. If they're underperforming at work, but it doesn't mean they're mentally unwell, but they can get help. Then this person who has a brother-in-law suffering from schizophrenia for more than 30 years, and no one was taking care of him. He ended up at the market. Sorry about that. It's called the drift theory. Can he get better now that we have put him on treatment? Thank you for putting him on treatment. Please follow up. He's likely to get better. Please support him. The role of family. I had seen another question. I can't see it anymore. The role of family in prevention and management of mental illness cannot be overemphasized here. It's important that the family members get involved in the treatment. I hope he's on a long-acting injectable antipsychotic, because that would really help so that he doesn't have to pop pills every day, antipsychotics. He can actually get a monthly injection and he might be able to get back to normal functioning. Then we have community mental health, where people are managed in just close to where they stay, in the community where they are living. So they walk to the health center, they are treated there, they get their monthly injection from there. You will be surprised. Once he gets to know where that community mental health clinic is, he'll even take himself. If he doesn't show up, then the social worker at the community mental health clinic will come and give him the injection at home. So then don't marry that girl. She comes from a family that has mental illness. There is the genetic risk of mental illness, but it is not, I would say there is no complete penetrance. Like if a father has a son, he has hemophilia, the father has hemophilia, then the son will inherit the hemophilia from him. If the mother is a carrier and marries somebody with hemophilia, then their son will have hemophilia. So, but mental illness may skip generations. So we don't want a situation where it looks like now you can't marry from that home because those ones, it's not every family member there who has a family, who has mental illness. But as we said, we are all at risk. So then, now that mental illness is a non-communicable disease, we need to identify the risk factors and then engage in self-care, avoid using substances. Then whenever we have any crisis, we seek help before it goes out of. Then these are vulnerable groups, especially low socioeconomic status, who have no access to mental health services and practitioners. These are the ones who progress to psychiatric disorders when even become suicidal. What measures have been put in place to reach the less fortunate? I would like to talk about community mental health and also the decentralization so that you don't have to come to Mathari Hospital to be treated for a mental health problem. You can actually go to the dispensary next door and find a nurse or a clinical officer who has been trained in mental health, who will do the screening, make a diagnosis, see what they can do. If it's beyond them, they will then refer. So we have people being trained at the grassroots and referral pathways that are in place. It's unfortunate that we are not as many psychiatrists as to be in every part of the country, but that is what is happening so far. What about the treatment patterns when they can't afford it? Now, as much as possible, we hope that there's, I don't know now whether it's a social health insurance or now it's national health insurance. If we could have insurance for everyone, then the issue of affordability would be out of the question. So we are hoping that in the new dispensation, we will have our patients covered for all mental illness. Then what happens when all sessions and counseling reaches the wit's end? What happens when that happens? Does it mean then you give up? No. If you have done counseling session and it is not working for you, you need to be referred for a psychiatrist to see and find out why the counseling is not working or whether you needed counseling in the first place. Because if, for example, the issue was psychosis, then you start with counseling, it doesn't work. Why does Mathari look so gloomy? Oh, have you visited us? We have flowers from the gate. We have good lawns. My late uncle was admitted there. And whenever I visited him, it broke my heart. Is there any plan for the facility to be improved? Thank you. I'm really sorry for what it looked like several years ago, but I challenge you to come tomorrow. You'll be surprised. The flowers start from the gate. There is good signage. You can't get lost. And please bring your uncle for a clinic because now he's no longer admitted. Then you can give us feedback on our services. But I'm really sorry if things were that way that time. And probably you can, maybe, Memphis, we can link the person with our PR person. We can see how it is that we can improve better. So Memphis, you get the person's contact? Or Ivy? Hello.
No, yes, I will. I will get the contact.
Oh, sorry. I was afraid I'm alone. I'm sorry
No,
about that.
no, you're not alone, but we have really gone past our time. So we would like to
Oh,
wind up. Maybe,
okay.
Doc, if you'd like to add anything else before we wind up.
My parting shot would be, let's choose good mental health for ourselves, for those we love, for those around us. So if you're an employer, please choose good mental health for your employees. If you're a pastor, if you're a traditional healer, if whatever identify any people with the warning signs and refer them to the nearest health facility. So then now for each of us, as we go to sleep tonight, I want to make sure that we all sleep more bet, like the French will say, that healthy habits on a daily basis ensure that we start thriving. Let's stop operating on survival mode. Thank you for your attention.
Thank you so much for your time, Daktari. That was very insightful. We've been able to get hundreds of people, and hopefully we have made an impact. Kindly send clapping emojis for Daktari and for their presentation if you've understood something. Thank you so much. I see a lot of thumbs up, a lot of hearts, a lot of claps, celebration signs. Thank you so much for your time. We have gone a whole 30 minutes past the time limit, but we really thank you for your time. Debunking these myths is crucial for us to be able to foster an environment of understanding, so that even as we go and support each other out there, we are able to come from a point of understanding. I've shared on the panel the 30-day self-care challenge that we are doing as Madare. You can be able to take a screenshot of it if you'd like. And I'd like us to end it there. Thank you so much for your time again. Have a good night.